Hello, everybody. Welcome to this weekly webinar of CCI, which happens on every Thursday at 8 p.m. without fail. So, this is the fourth of the series of webinars related to sleep-related breathing disorders. And at the very outset, let me thank CCI founder Dr. N.H. Krishna, trustee Dr. Narayan Pradeepa, webinar coordinator Dr. Jaykumar Chennam Chetty, CCI President Dr. Ashish Dubey, CCI National General Secretary Dr. Anil Maske, and the course coordinators, my dear friends Shivani, Swami, and Dr. Ravi, Dosi, for having given me this opportunity to be the moderator of this session. This session on sleep-related breathing disorders is mainly focusing on the treatment aspects, which is perhaps the most important part of any discussion on sleep-related breathing disorders. And for this, we have a very eminent panel today to discuss the important and urging, pressing questions that all of us have in our minds when we think about treatment of sleep disordered breathing. Our first panelist is Dr. Atri Gangopadhyay, who is a pulmonologist from Ranchi, Jharkhand. He has his own center, which is equipped with PFT, complete PFT, sleep study, and CT scan. And he is also the pioneer of oscillometry in the eastern part of the country. And more importantly, Atri also happens to be the East Zone Governor of CCI. Welcome to this webinar, Atri. The second panelist that we have is Dr. Karl Mehta from Bengaluru, who has had extensive training in sleep disordered breathing from an international perspective. He has been a World Sleep Society International Sleep Research Training Program Fellow in 2022. And he has also worked as a clinical fellow of sleep disorder at Sleep Disorder Center and Guy's and Thomas NHS Foundation Trust Hospital 2023-24. Welcome, Karl, to this program. We have Dr. Jaykumar Mehta from Ahmedabad, who has been a gold medalist for MBBS. He's also done MD, DNB, MNAMS, and also has done his postgraduate fellowship from CMC Vellore. He's a consultant interventional pulmonologist, also has interest in allergy, asthma, and sleep disordered breathing. And he works in the EPIC Multi-Specialty Hospital, Ahmedabad. We have Dr. Tarang Kulkarni from Thane. Tarang has DNB and he's also an European diplomate in adult respiratory medicine, working as a consultant pulmonologist in Jupiter Hospital, Thane. So welcome to this program, all the esteemed panelists. So to start the program, we have two brief presentations just to set the context for today's panel discussion. First talk, I'd like to invite Dr. Atri, who will tell us about PAP therapy in sleep-related breathing disorders. Over to you, Atri.
Thank you, Dr. Arjun, sir, for the kind introduction. I am Atri Gangopadhyay from Ranchi, Jharkhand. Wishing everyone here that you all had a wonderful Christmas and looking forward to the year end and New Year celebration. So, I want to talk today about PAP therapy in sleep disordered breathing. Here, PAP does not belong to the gynecology of CA cervix. Here, PAP stands for positive airway pressure. I would want to acknowledge Dr. Shivani from Jaipur, Dr. Chennam Chetty Vijaykumar from Hyderabad, who helped me with the resource material for this presentation. Look at this diagram. Obstructive sleep apnea is when the airway collapses, stopping air from traveling freely to and from your lungs and disturbing your sleep. Now, this obstruction can be at multiple levels, starting from the external nostril to beyond the epiglottis or at the entry of larynx. At multiple levels, the obstruction can be there and it worsens during the supine position or during sleeping. So, positive airway pressure is something that blows air, bypassing the obstruction, allowing a clear passage, leading to better breathing. Now, this is as per the standard guidelines AASM 2019, treatment of adult obstructive sleep apnea with positive airway pressure. So first, we need to establish the diagnosis by a clinician and supported by a objective sleep testing. Then we need to decide, does the patient have excessive daytime sleepiness, reduced sleep related quality of life, or hypertension? If the answer is yes, we need to discuss the treatment options like wet PAP therapy, and do the patient and the clinician agree? If no, think of alternative therapy. If yes, does the patient have significant comorbidities? If yes, then initiate PAP using in-lab strategy. If no, consider initiating PAP at home. Now, if there is no such problem, then we need to talk about educational interventions. Consider using behavioral intervention, follow up using telemonitoring, and if they don't work, then think about PAP initiation. Additional considerations is the use of the interface and use of humidification. We shall discuss all of them. So what PAP therapies does is that air that blows through that mask ultimately bypasses the obstruction at the multiple levels, keeping the breathing passage open during sleep. So the dilemma which we face every day is choosing the right device, whether it should be a CPAP or APAP, auto bilevel or bilevel, whether humidification is needed or not, whether internet connectivity is needed or not, noise level of the device, if the patient is a frequent traveler, portability of device, and obviously affordability or finance. Look at these diagrams. CPAP or continuous positive airway pressure. So the pressure of the device does not change over time. APAP, automated positive airway pressure. So depending upon the patient's breathing resistance, the pressure can change over time. Bilevel. Here there are two pressure, one is a inspiratory, one is expiratory, and auto bilevel. Here also there are two pressure, but there is a fluctuation for both the pressures. So ultimately, whatever machine you have in the market boils down to these four things. So continuous positive airway pressure or the landmark device first described 1981 by respected Dr. Professor C. Sullivan and team. Most effective non-invasive therapy. Even now, this is perhaps the most popular device experienced. So look at the diagram. On the left side, you can see a apnea, that is the tongue is pushing over the epiglottis. And with the PAP therapy, the air comes, creates a splint, allowing the tongue to move away from the obstruction place. So what are the beneficial effects of CPAP therapy? It decreases the blood pressure, improves heart function, improves quality of life, decreases cardiovascular event like stroke or heart attack. It improves sleepiness and cognitive function, decrease incidence of accidents, improve depressive symptoms, improves diabetic control. Next we come to the APAP or automatic positive airway pressure. There is a dynamic device and the pressure varies depending on the patency of the upper airway, and it is considered more comfortable as the pressure delivered changes with the needs of the individual. So how does it work? If there is a respiratory event like snoring, apnea, flow limitation, upper airway impedance, then the pressure level increases, and if there is no such respiratory event, then the pressure level decreases. Now let's come to bi-level devices or BiPAP, or also popularly known as NIV. Here there is a higher pressure on inhalation, lower pressure on exhalation. Every sleep apnea patient does not need this, but wherever there is a OSA non-tolerant to CPAP or APAP, please consider BiPAP. Overlap patient, like patient with a sleep apnea and a chronic obstructive pulmonary disease. Next, nocturnal hypoventilation syndrome, complex sleep apnea with a need for reliable ventilation rate. Such cases, we need these bi-level devices where there is two pressure, a higher pressure on inhalation, a lower pressure on exhalation. Auto bi-level would be something like that auto CPAP device, but for a bi-level. And this can be used on OSA who is unable to tolerate that CPAP or APAP. And the easy breathe waveform adapts to the patient's breathing cycle to produce a comfortable, natural breathing experience. Some newer devices, IVAPs, intelligent volume assured pressure support. It maintains a preset target alveolar minute ventilation. The monitors delivered ventilation, adjusts pressure support, and provides an intelligent backup breath. So, where other than sleep disorder, there are disorders of ventilation, this is something wonderful. This is something practice changing and changing the lives of patients. IVAPs as a BiPAP or NIV in spontaneous breathing patient for non-invasive application, patients who weigh more than 30 kg, especially for treating hypercapnic respiratory failure. No, it is not just about the device. It is also about the interface or mask. Some people are comfortable with a face mask. Some people may need a nasal mask. So these are diagrams of the various types of masks, and you need to try multiple interfaces when you finalize that yes, this patient is more comfortable on this interface. So what may be the common challenges in OSA patient? Mask leak, mouth leak, dryness, difficulty in exhaling, and treatment emergent disorders. So look at these very brief flowcharts. Suppose someone needs a maximum pressure of 20 centimeter of water. Then you can think of transitioning this patient to BiPAP if there are continued breathing events at 15 centimeter. Now, come down by 5 centimeter and greater than 30 minutes without breathing event. Then you can try to decrease the pressure by 1 centimeter, and this way you can go lowest to 4 centimeter water. Now, suppose you need a pressure of 30 centimeter, then the inspiratory pressure, positive pressure may be increased further. You come down slowly by 5 centimeter. If you get better, then you come down slowly by 1 centimeter. So minimum IPAP 8, EPAP 4. So this is how the various algorithm for tapering the continuous PAP or the bi-level PAP. So now I would want to pass on to Dr. Karl Mehta. He will tell us more regarding the non-PAP portion of the therapy. Over to you, Dr. Karl.
Good evening, everyone. My name is Dr. Karl Mehta from Bangalore. I am a pulmonologist and also have done 1 year of sleep training at Kaizen St. Thomas's NHS Foundation Trust at the Sleep Disorder Center. Thank you for having me. I hope you find this presentation useful. So I'll be focusing on the non-CPAP treatment options available for sleep-related breathing disorders. So as we know, CPAP is highly efficacious, and it is very useful in patients who have or diagnosed obstructive sleep apnea. But it's particularly useful if it's moderate and severe OSA. However, in mild OSA, it's debatable, and there are now alternatives that can be done. Certain things that can be easily done are encouraging the patient to lose weight, especially when they have a large neck and a large waist to hip ratio. So you can encourage diet and weight loss and refer them, as well as if they have any endocrine disorders that can be diagnosed and appropriately treated. Losing weight by about 10% does make a difference to the AHI index as well as their sleepiness scores. So these are something that are positive. You want to diagnose metabolic syndromes like hypothyroid. If patients have acromegaly, that can also be treated. Looking for concomitant sleep disorders like restless leg syndrome or insomnia, and identifying that and treating that will also show some benefit. If the patient has chronic pain, that needs to be appropriately diagnosed and treated or managed appropriately. Any psychiatric illnesses need to be effectively managed and treated as well, because these all play a role in compliance of therapy in patients with obstructive sleep apnea. While there are no direct medications to help, there's no single pill that can do this. We do have GLP-1 inhibitors. Most recently, we have tirzepatide, which has come out recently and has been published recently as well on its effects on weight loss, especially in the pre-diabetic and the diabetic population. They've done a 176-month study, and the results are very encouraging. Also, identifying things like rhinitis, rhinosinusitis, allergies, insomnia, and those who are persistent, have CPAP intolerance or persistent excessive daytime sleepiness as a result of CPAP, then you need to think of changing the treatment plan or adding on other treatment options. For example, if your patient's already on CPAP, you may want to consider giving him a mandibular advancement device in addition to CPAP before maybe escalating to bilevel. So I'm now going to focus on 4 main areas of non-CPAP therapy in terms of that can be done in addition to weight loss, which are oral appliances or mandibular advancement devices, positional therapy, surgery, and a combination of these factors. So in terms of your oral devices, you have the mandibular advancement devices and the tongue retaining devices. Of the two, the mandibular advancement devices is the one that showed the most improvement, especially in patients who have mild obstructive sleep apnea and the mild to early moderate obstructive sleep apnea. So if you look at the image here, you would see that those patients without a use of mandibular advancement device, if you find that the velopharynx is quite narrow, and then there's a narrowing again between the oropharynx and hypopharynx. Whereas when the patient is using the mandibular advancement device, you find that these diameters increase, and this narrowing between the oro and hypopharynx is practically eliminated. This is exactly what you see when a patient is awake. So that's one of the benefits. If you look at the meta-analyses outcomes, when compared to the patients who have had sleep study versus the sleepiness outcomes, so you find that if you look at the AHI trends, the higher the AHI, CPAP is going to respond a lot better compared to mandibular advancement device and the sham MED. Whereas if you look at the sleepiness outcomes, like the Epworth sleepiness scale, the maintenance wakefulness test, or the Osler test, there was significant improvement using either CPAP and mandibular device. That's the same, but sham MED proved to be useless. There was a Philips Tomato study that was conducted, and it showed that the CPAP, with higher AHIs, CPAP will be more effective compared to mandibular advancement device. But when it comes to sleepiness outcomes, the CPAP and mandibular advancement device showed the same outcomes. So in terms of the crossover, there was a crossover study when you look at the health outcomes in CPAP versus oral appliance. And this RCT showed that in 126 patients diagnosed with moderately severe obstructive sleep apnea, hypopnea syndrome with an AHI of 25.6, they found that the outcomes that if you look at the CPAP definitely helped reduce the AHI if you look at AHI. But if you look at the other sleepiness factors, other factors involved, they found that CPAP as well as mandibular advancement device can help reduce 24-hour blood pressure levels, can improve the Epworth sleepiness score. They show the similar outcomes on the driving simulator, and it also shows good outcomes in terms of quality of life. So it's significant. However, mandibular advancement device is preferred over CPAP because it provides better patient comfort. And when the patient is more comfortable and less hindered by the obtrusiveness or where the claustrophobia caused by the CPAP mask or the pressures of the CPAP, the compliance was better. So you had a 6.5 hours a night compliance data with mandibular advancement device as opposed to the CPAP. But I think this graphic is very informative. And if you look at the convenience factor, the tolerance, the patient adherence, and the partner tolerance and comfort levels, the adherence to the patient, health benefits, symptom control, all these were better with mandibular advancement device as opposed to the CPAP. Where CPAP stands out is what the polysomnographic efficacies, which is something that we can quantitatively achieve and through the sleep study or polysomnogram. So that's the main positive record was CPAP. But in terms of other things, the mandibular advancement device was more comfortable. There are different types. You have the thermoplastic, the semi-bespoke, and the bespoke. I will just show you those real quick. So this is your image of the boil and bite, very generic, over-the-counter, poor compliance and adherence because it continuously slips out. So the usage was very poor. If only in patients who really were diligent about it did they find did they improve in their symptomatology. Whereas a semi-bespoke, again, has some molding. It does help sit on the teeth a lot better, is a little more comfortable, but is not as good as the bespoke one. But for the bespoke mouth guards and mandibular advancement devices, they need definite dental intervention. But if you look at the results here, you definitely see that the mandibular advancement devices help reduce AHI. But again, you have to bear in mind that it's in the mild or mild to early moderate CPAP patients with a mild to early moderate AHI levels, where you see this improvement when they become mild CPAP or normal. But it clearly shows when it comes to the Epworth sleepiness scale, they found that the semi-bespoke and bespoke were just a lot more comfortable and a lot better in terms of long-term use and adherence. So in terms of dental criteria, it's just important to bear in mind when you're looking to prescribe mandibular advancement device for your patients, you need to make sure they have adequate teeth. You need to make sure that the temporomandibular joint, there's no pain. There's that's important. Then look at the quality of the gums, whether there's inflammation, whether there's loose teeth. These are all things that need to be taken in mind. It should be hygienic. Otherwise, refer to your dentist before prescribing mandibular advancement device. So in terms of responses, the response will be ideal if you have a patient who has mild OSA, who has supine-related OSA, who has a low BMI and a low neck and doesn't have a large neck circumference and has no oropharyngeal crowding. These are the important points to note. And this is the ideal patients to provide a mandibular advancement device in. Whether females would benefit more from males, whether the younger versus the older population, this data needs to be studied further. But I think it's important that you take your experience into consideration and patient's response into consideration. We also have drug-induced sleep endoscopies that are available. Again, very limited. It's very specialty-based, niche. Very few ENT consultants actually performing this. Some pulmonologists interested in sleep are doing DICE now. But again, it's not something that's a regular practice. It is if there's significant airway narrowing, then just using a mandibular advancement device may not be the answer. You can do a 3 to 6 month trial otherwise, and then they do it again with when the device is in place. You do another dice and see whether there is a positive response, there's a significant dilatation of the upper airway or not, and then they take a call whether to continue it long term or not. There are electronic or remote controlled mandibular protrusion devices and oral devices that are available. But again, and you can see whether the prediction of success and failures are there. But these are again, it's case by case really, and not enough long-term data available. In terms of supine positional related OSA, again, basically patient having significant obstructive sleep apnea on supine, but a low AHI, they'll respond better to this treatment. If you have a high AHI with high supine OSA, then CPAP therapy is first line. But in the first instance, you can consider using a positional therapy, because when you lie in lateral position, your tongue doesn't fall back, and you're able to the upper airway is open a lot more in these patients. So it's more recommended in patients with a mild OSA, and this position change does show a significant benefit to both the data as well as the symptom profile. So just wanted to show you here's a polysomnogram, and if you look at this patient here, this is the area where you have low saturations, high number of desaturations, high number of obstructive airway events, and the patient is in supine. But the minute you change this patient from supine to the right lateral position, you find that the SaO2 desaturations have reduced to baseline. He has little to no obstructive apneas, and therefore they're going to feel a lot better, and they sleep a lot better at this position. So there are sleep positional trainers, there are belts, there are other devices that are available in the market, and this is easy to demonstrate that they start with a AHI, say a moderate AHI, and then they come down to within normal levels, as long as patient selection is key in this patient, able to diagnose the ratio between the AHI and with supine related AHI, and then prescribing this therapy. What about the role of combination therapy? For example, using a mandibular advancement device with positional therapy. In patients when you look at the baseline, if you see the baseline in patients with mandibular advancement device, there was a fall. If you baseline with patients who required positional therapy, there was definitely a fall. But if you used a combination of mandibular advancement device and positional therapy, there was a clear decrease from baseline and it's almost reaching the normal range. So this is something that needs to be considered. Again, the caveat is important to have patient selection, important to look at the data pre-diagnosis and post-therapy, wait at least 6 months and see. In terms of surgical options, this remains an area of debate. It totally depends on the center. It depends on the training of the surgeon, and so it requires a significant patient selection and expertise. So these are the limiting factors. So this can be done. The treatment option obviously is uvulopalatopharyngoplasty, but again, in selected cases, you also have maxillomandibular advancement surgery. This needs to be taken into account with the patient's dentist. And the last part I want to just get to, I need 2 minutes here, is hypoglossal nerve stimulation. So what we have is you have a device which is kind of like a pacemaker device with a neurotransmitter stimulator here. So the battery device, it's connecting to your intracostal muscles, and then with another lead going to the hypoglossal nerve, which sits below your hypoglossal muscles. And basically what it does is provide stimulation while the patient is asleep to cause contraction of the palmopharyngeal muscles as well as the glossus muscle, genioglossus muscles, causing the tongue to move forward. And what they found is inclusion criteria include BMI of less than 32, and AHI between 20 to 50. The DICE should exclude large tonsils, and concentric retropalatal collapse should be absent in these patients. We do titrations, obviously pre-operative, and then at 2 months and at 6 months. And definitely the graph shows that from around 30, with proper compliance, in a 12-month period, it was almost close to normal. But if you withdraw the therapy, then there's a chance that this can recur again. So just wanted to let you know, in terms of learning objectives, it's patient selection is important. I hope that people can look at using mandibular advancement devices in their mild patients, consider the other options as well, based on a patient, and tailor make your treatment options to each patient. Thank you very much. And I look forward to answering your questions in the Q&A.
Thank you very much, Dr. Atri and Dr. Karl, for the excellent lectures that you gave. So that actually sets the context for today's panel discussion. We are basically going to discuss various aspects of treatment of sleep disordered breathing, which is something which is of interest to all practitioners who are involved in treating sleep disorders. So we'll start the panel discussion. I will first start. The first question is to Dr. Karl. As you have mentioned in your lecture, again and again, there are a lot of questionnaires that we can use in our day-to-day practice to screen patients who are suspected to have sleep disordered breathing. Can you throw some light on the role of these questionnaires in day-to-day practice?
Absolutely. Thank you, Dr. Arjun. So the most important questionnaire by far, which should be in every sleep practitioner's mind, is the Epworth Sleepiness Scale. That is the questionnaire that is still given a lot of weight because it covers the entire spectrum of sleep disorder breathing. Whereas if you look at just the stop bank is only useful as a screening tool for patients with OSA. So that's the main takeaway message. But the screening tools that are available, that are there, are to be used only in clinical context. So you need appropriate history, and you need then to use this in context. So there are other screening tools out there, which are like the one from the University of Pennsylvania, where they use it, where their questionnaire focuses on sleep related with patients with some psychiatric disorders. Some of the neurology teams have a different questionnaires. So there are various questionnaires that can be used. There are other questionnaires that can help with certain complex sleep disorders, those with a greater psychiatric or a neurological preponderance as well. So those also can be taken into context. So just have a look into those when you get time when patients come by. But the gold standard takeaway will be ESS. One more thing is using questionnaires not only as a screening tool pre-diagnosis, but once treatment is initiated, on follow-up, you need to ask these questions again, just to make sure that your patient symptoms remain controlled. That means ESS will remain in the normal range. Because if it again tends towards the pathological range, then you should raise questions as to use of therapy, adherence, and compliance. Thank you.
Thank you, Karl. We have really highlighted the important questionnaires, basically the Epworth Sleepiness Score and the Stop Bank questionnaire. And just to highlight the point that Epworth Sleepiness basically looks more into the sleepiness part of it, and Stop Bank basically it's an easy tool which can be used in day-to-day practice to identify perhaps patients who are at high risk of having sleep disordered breathing. We'll now go to Dr. Tarang.
So one comment, sir. Sir, when it comes to stop bank questionnaire, you think it can be used safely in Indian patients? I mean, or do we need more sort of validation when it comes to the Western cohort as compared to our patients?
That's a very good question, Tarang. Yeah, Karl, please go ahead.
Sorry, please go ahead, sir. I'll answer after you. Thanks.
No, yeah. About basically, stop bank is the one that we use regularly in our day-to-day clinical practice. So that the 8 scores, if it is more than 5, we know that the patient is at high risk of having sleep disordered breathing. Having said that, the parameters like the neck circumference perhaps may be a bit different for the Indian population as compared to the West, and I think we need more studies from our part of this world to probably slightly modify it to suit our requirements. Over to you, Karl.
Just one caveat. Yeah, the stop bang is poor even here. I mean, it's a poor indicator. You have a lot of patients who have under exaggerated or low stop band scale who also have sleep apnea. In fact, we see 50% of the population in the UK actually having normal neck circumference. And in our Indian population, we also have this the rice belly, where it's just where it's only in the abdominal area where we get obese, not as common in the upper airway. So again, using it in clinical context, and like Sir said, is the best way to go about it.
Thank you, Tarang. The next question is to you. What is the ideal time to do a polysomnography, especially if the patient has been an inpatient after admission? We usually do sleep studies on an outpatient basis when the patient comes to us for evaluation. But if the patient happens to get admitted, when do you suggest a polysomnography, and what are the reasons for your choice of timing?
So thank you so much for that question, sir. So this is a very common scenario that we face, because most of the patients with sleep evaluation, you would get references from either cardiology or from general medicine, where a patient is having sort of heart failure or any hypertensive emergencies, where the patient is more likely to also follow your advice. So, but the primary thing that we have to keep in mind, that there should be stabilization of the acute condition why the patient is admitted into the hospital. So it either could be respiratory or it could be cardiac. So correction of things like heart failure is extremely important when you would actually consider doing a polysomnography for the obstructive sleep apnea. Now, early testing in these individuals likely would lead to false results, and it could be potentially because of reasons like oxygen supplementation or having some sort of a residual effect of sedation, especially if they were in the ICU. These patients also suffer from from admission fatigue, and they could have an altered sleep pattern, especially when they are in the hospital. So most of the guidelines recommend that there should be a sort of 2 to 4 week period where you would wait, you would reassess the patient in the outpatient, and after that you would consider doing a sleep study in these cases. Now, having said that, there are certain exceptions to this rule also. So immediate testing would be recommended in severe cases where there is a suspicion of having severe OSA, and in conditions where OSA could contribute to acute decompensation. Things like concomitant heart failure or things like concomitant obesity hypoventilation syndrome. But in a nutshell, I would still wait for 2 to 4 weeks after an admission to make sure the patient is at its baseline, and then consider doing a sleep study in this cohort of patients.
Excellent. And the point is
I would put in a quick point over here. Where I work, the neurologist at my hospital, whenever there is a CVA patient admitted, and stable CVA means not those hypertensive emergencies like hemorrhage, etc., but an embolic ischemic CVA, he makes it a point that before discharge, he gets a sleep study and gets it evaluated by me before discharge. Because often in CVA, what happens, one very big problem in sleep medicine is the budget, the finances. But in CVA, in insurance patients, that sleep study is reimbursed.
So, Atri sir, would you be comfortable in doing a sort of an overnight oximetry as compared to a complete PSG in these patients?
We do complete PSG.
Okay.
Yeah, that's a very important point, Tarang, as what Atri has said. It's very important to do a complete polysomnography in such patients and not merely rely on looking into oximetry alone, because there are many other conditions in which you can get a desaturation, and so you might be missing it totally. So that is a point well made. And as you said, it's ideal to do it when the patient's clinical condition has become stable. Let's now move on to Dr. Jaykumar. Mehta, this question is to you. What are the clinical indications for starting PAP therapy? Both you.
So I think this is very basic and fundamental question, because we all have been across treating sleep-related breathing disorders. Usually, we differentiate them between obstructive sleep apnea and central sleep apnea. And then there are other disorders like obesity hyperventilation syndrome. And then there is also a very nice talk from you only about the overlap syndrome and how to diagnose it. So we'll be restricting our talk for PAP therapy, that is positive airway therapy, into the SRBDs. So PAP therapy is basically a device which will give pneumatic splint to the upper airways in a spontaneously breathing patient with the virtue of an interface, whether it is nasal or orofacial. Now, the thing is that when we are thinking to give this device to a patient, first and foremost, it's for the long term. And second, it comes with significant cost and financial aspects. And third, with the maintenance. And hence, it is very important for us to identify that what effect we are getting and which device shall we select for this patient to get the optimal benefit. Now, first and foremost, the PAP therapy has been shown remarkably good in decreasing excessive daytime sleepiness symptom in obstructive sleep apnea patients. So there is no doubt that when you are having a sleepy patient, when there is excessive daytime sleepiness, where you are having PSG showing moderate to severe OSA, where AHI more than 15, but these are the patients where the PAP therapy will do wonders. The second is where we have a bit of confusion whether it may not. It's called sleep related or impaired sleep related quality of life. Like it can be snoring. Snoring can be cumbersome to even the life partner or sleeping partner. Then there is nocturia. Then the breathing which stops at the night time. So choking sensations, as well as this type of thing, which are not per se excessive daytime sleepiness, but it impairs your sleep experience, and you may not get good outcome. Now, in that patients also, if your PSG is showing that there is definite OSA, you can definitely give, and you need to reassess at periodic intervals. Now comes very important aspect where the patients which we get referral for systemic hypertension, particularly resistant hypertension, where the PAP therapy has shown that addition of CPAP lowers the blood pressure as well as it reduces the risk of ischemic heart disease and events. So systemic as well as pulmonary hypertension. OSA has been classified as in group 3 of pulmonary hypertension by WHO. And hence in that also PAP therapy improves the outcome. Fourth is about the heart failure and arrhythmias. Like certain studies have shown that once the patient is optimized on the antiarrhythmetics, still, if you are having or missing OSA in those patients, the chances of recurrence are up to 82% in non-PAP group and 42% in PAP group. And hence in heart failure and arrhythmia patients, giving PAP therapy, although if the patients are non-sleepy, it makes sense. And finally, it is improvement of the neurocognitive or memory, some memory or performance enhancers, which is still in doubt. So in nutshell, we are having a classic phenotype where there is excessive daytime sleepiness, where it is going to work. This is a group of patients which will come to us directly. And the second will be referred from either the cardiologist or neurologist for either systemic or resistant hypertension, pulmonary hypertension, heart failure, difficult to control arrhythmias, even glucose metabolism. I have many friends who are endocrinologist friends who are sending me for sugar control because they are on max and they're suspecting intermittent hypoxia as a chief reason. So in those patients where there is not much of indication of sleepiness, still the PAP therapy works at its best. In those patients where you are having you are addressing the comorbidities, it is very important what you are looking at, and you have to explain that this may lead to, it shows that it may lead to improvement in your comorbidities, and hence it is very important to have the communication. So in nutshell, these are various indications of the PAP therapies.
Thank you, Dr. Jaykumar. You have wonderfully summarized it. So basically, the important take home is that any patient who has moderate to severe sleep apnea needs to be treated. And if it is a mild sleep apnea, even in the absence of daytime sleepiness, if the patient has some comorbid condition like hypertension, arrhythmia, cardiac failure, uncontrolled diabetes, it is again an indication to start the patient on the appropriate treatment. Thank you so much. We'll now go to Dr. Atri. Atri, this is a tricky question for you, actually. So we have certain instances in which the physician will suspect sleep apnea and without doing a sleep study will start the patient on PAP therapy. So what do you think? Is there any justification to do so? And what are the harms if someone initiates PAP without doing a sleep study?
One thing we must understand that PAP therapy is something like a permanent therapy. Very few proportion of patient need PAP therapy for a intermittent period, let's say 3 months, 6 months, and then stop it. Most of the patient for sleep apnea require PAP therapy for lifetime. So if I am giving a treatment for lifetime, it is very important to diagnose it properly. There are certain differentials of sleep disordered breathing. One very common overlooked diagnosis is an intermittent nocturnal asthma. We may suspect it's sleep disordered breathing. It may be nocturnal asthma. Next, some undetected heart disease, especially this aortic valve, it plays lot of nasty leading to this paroxysmal nocturnal dyspnea. And we may consider it as sleep disordered breathing. So rather than treating the right problem, we may compound the problem. So number one, please establish the diagnosis so that we don't miss this common differential diagnosis. Second, prognostication. For example, a AHI of mild grade with a significant desaturation would require treatment than, let's say, of a AHI severe grade without any desaturation or without too much of tachyarrhythmia. So prognostication, not only the number of AHI, but regarding desaturation, regarding arousals, etc. So, however resource limited setting you may be, but before starting PAP therapy, please document with a sleep test. And there are lots of courses in India now with respect to sleep medicine. So doctors are also quite common, and availability to a sleep machine is also quite common.
Absolutely true, Atri. Very, very well worded. In fact, I think always make sure that you're dealing with the right disease before you start treating. We'll now go to Tarang. Very important practical question to you, Tarang. See, when we start the patient on CPAP, we know that the adherence to CPAP is very low. We ourselves have done a study in Trivandrum, in which we have proved that the CPAP complaints and adherence is only 25%. So the most important thing is the troubleshooting once you start a patient on CPAP. So what are the primary challenges in resolving issues related to the CPAP device, and how can patient adherence to CPAP be improved? Correct.
So one of the most important aspects of CPAP troubleshooting CPAP troubleshooting would be first assessing if the initial settings and all are fine. Many times the patient goes somewhere, he gets the machine, and then it turns out the settings which we had prescribed are not given, but some other or the patient has been put on again an auto mode. In case if the settings and all are fine, then you would think in terms of if the patient is having any treatment emergent apneas or any other AHI is not getting corrected by this certain settings. In any case, there are a few things that we have to look for. We have to look for mask related discomfort. If the patient is comfortable with his mask, are there any excess leaks, or is the patient having mouth breathing? All of these issues have to be addressed. Similarly, any sort of facial hair which might be interfering with the leak of the mask of the patient generally needs to be addressed. A few patients also complain of dryness, excessive dryness of upper airways after using the mask. In this particular cases, humidifiers may be used. Especially in female patients, there could be a cosmetic issue where there are sort of pressure sore like changes on the bridge of the nose. And in this particular case, you can change the mask to something like more friendlier nasal pillows, or you can use those Comfeel patches, which generally would prevent them from having this pressure sores. There are a few psychological barriers as well. There is stigma associated with CPAP still, especially patients who are frequent travelers. And I think counseling in these patients potentially could also help. In young patients with OSA, something that patients come and ask are issues related to intimacy, which could generally contribute to psychological barriers. A few devices, especially if they are old, could be noisy. They could be complex devices, which switching to new models can help. especially now that we have models which are connected to the internet, and the patient can monitor his sleep based on iOS or iPhone apps, etc. Aerophagia is one of the other issues that needs to be addressed, where the patient has a lot of gastric bloating, a little bit of prokinetic generally, or revisiting the pressures that were given generally could be helpful in these cases. Irrespective of all these troubleshooting events, monitoring and feedback with your patients is very important. You would generally want to look at the compliance data about how much the leak and how much the AHI was, which potentially could help improve your sleep outcomes.
Thank you. Tarang, I think you have summarized everything very well. Mask leak is an important thing, dryness of mouth, aerophagy, these are the important things. And this again highlights the importance to ensure that you call the patient for follow-up at regular intervals, see the CPAP data, and see whether what are the problems and how to overcome that. The next question, again, a very practically important question, something which often comes to our mind when we have a patient with sleep apnea, is that what machine are you going to prescribe? Should I prescribe? Should I prescribe a manual CPAP? Should I prescribe an automatic machine, or whether the patient needs a bi-level device? So how do you decide on this, Dr. Jaykumar?
I think, so again, very fundamental question about APAP, CPAP or BiPAP. So first and foremost, it depends on very in-depth analysis of your sleep study polysomnography, that the patient is having pure obstructive sleep apnea, or the patient is also having central sleep apnea or a mixed apnea thing. Now, why it is important? Because obstructive sleep apnea is mainly over the nasopharyngeal airways, where the CPAP will have a very good effect. It will increase the upper airway volume by around 20%. Mainly, it will act by expansion of the lateral air volumes and thinning the pharyngeal walls. Now, what happens is, if we are having CPAP, it will deliver a continuous set of the pressure, which is titrated usually when the patient is in lab. And there are standard manual titration protocols. And once we said that, the patient usually receives that. Now, auto CPAP is something which makes the experience very smoother. If a patient has certain recreational activity like alcohol consumption or having a sleeping pill, then or some positional change, then auto will sense that and will titrate the pressure and give it accordingly. It is very beautifully described in Dr. Atri's presentation how auto CPAP adjusts the pressure and makes night more comfortable to the patient. And hence, when it comes to different to choose between CPAP and APAP, the ASM guideline is very clear that there is no superiority of APAP over CPAP, but still patient compliance is more with the APAP. So but also it comes with somewhat more financial and it's a bit costlier than the manual CPAP. So we need to look at the patient's budget and then take a call on individual basis. But if we are treating with the pure OSA component, I think CPAP, APAP, both can be good. When it comes to central sleep apnea, then the first thing is we need to get to the CPAP and the OSA where the pressure requirement is very high. Suppose if we are going to more pressures, like the pressure requirements around 18 or 20, at that point of time, these are very high pressures, patient cannot tolerate and will lead to default. So in that case, BiPAP will make sense. Again, in BiPAP, as Atri sir has told in the presentation, auto BiPAP is somewhat which you can use in OSA, obstructive sleep apnea patients. But BiPAP with spontaneous time mode is one which we usually prefer when we have CPAP resistant CSA cases. BiPAP with only spontaneous breathing makes CSA worsen. So hence BiPAP with ST mode will lead to more abolishment if it is not abolished by the CPAP alone in the central sleep apnea component. So in nutshell, if the patients come with the pure obstructive sleep apnea component, based on the patient's comfort and budget, you can choose either APAP or CPAP. And if the pressures are very high, you can switch to the BiPAP in OSA and BiPAP ST if the patients are not tolerating CPAP in cases of CSA.
Thank you. Thanks, Jaykumar. I think you've put it all together very well. I'll just quickly summarize a couple of things. But before that, I'll ask Tarang whether he has anything to add to what Dr. Jaykumar has said. Tarang?
So I totally agree with whatever Dr. Jaykumar said. So just the thing is that when it comes to APAP titration or manual CPAP titration, If we are dealing with an uncomplicated OSA, there is no change in efficacy in terms of daytime sleepiness, tiredness, or quality of life. And there is enough data out there in terms of RCTs and even meta-analysis. Now, having said that, still an attended in laboratory titration study is still supposed to be gold standard. This might, but in patients who have complicated OSA, that are patients with concomitant COPD or heart failure, and in hospital titration studies still is recommended, because the protocols which are used in the auto pipe titration study might not actually pick up these complex apnea issues. So Dr. Jaykumar rightly said about the cost bit. Our manual CPAP, that APAPs are slightly more cheaper than manual CPAP or fixed CPAP machines, but having a manual CPAP in laboratory is also expensive. So I think it all goes down to, you have to find a balance between how much benefit you can offer to your patient.
Thank you. I'll just add a couple of points to what both of them have said. Number one is what we need to understand is that both manual CPAP and auto CPAP are equally effective. That is point number one. Point number two, there are certain conditions where you may upfront start on an auto PAP. That is patients who rapidly gain weight and lose weight. That is one group. Secondly, patients who have recurrent allergic rhinitis or rhinosinusitis. Again, they may have variation day to day, every night, the pressure that they experience. And thirdly, as Dr. Jaykumar rightly put it, people who are in the habit of taking alcohol off and on. So those days when you take the drink, the pressure requirements will be much higher. So for those group of patients, actually an auto PAP might be a better option than a manual CPAP. As far as a BiPAP S mode is concerned, it is nothing more than a glorified CPAP. So we use it when the CPAP pressure requirements are on the higher range, say 1920. But for all the overlap syndromes, OSA, COPD overlap, OSA, OHS overlap, we always prefer a BiPAP S3 mode. So those are the important things that we need to keep in mind. I'll come to Dr. Karl next. Does positional therapy make a difference in OSA, and what are the devices that are effective? I know that you've highlighted this in your talk, but could you just elaborate it once more for the benefit of our audience?
Absolutely. So just to understand, so positional therapy, what's happening is that the patient is lying supine and your OSA is getting worse. How is it getting worse? Because the airway is narrowing a lot more. So you're tending to have sharper falls in your oxygen saturation and increase in the apnea episodes, so that they can get to moderate to severe levels, whereas your overall AHI may be mild or maybe mild to moderate. So these are the patient groups that then require positional therapy, where all you're telling the patient is to lie on their side. Now, in many patients, if they're not used to lying on their side, it's just difficult for them to do it on their own, because when they go into deep sleep, they tend to move back to their natural sleeping position. So in order to prevent this, there are sleeping aids available, which are, there are all kinds which are on the internet. They're mainly positional belts, sleeping pillows, and there are electronic devices now that you can use, where they give electronic signals to the patient to maintain a position. So it just depends on, again, what's available and what the patient can afford. The main reason is that you use these aids because you want to end up making the patient lie in the lateral decubitus, whether it's left or right, and spend most of their time of their sleep time on those positions. So what that does is it increases the patency of the upper airway by opening it, and also prevents the tongue falling back, and prevents compensatory airway collapse as a result. And also with patients with enlarged tongue, this helps prevent the tongue from falling backwards. So these are the reasons why positional therapy is something that needs to be kept in the back of your mind when you have a patient with mild sleep apnea with supine-related increased events. So you need to be able to have someone pick that up in the sleep study. So that's also important. Thank you.
Excellent, Karl. You have brilliantly summed up the whole thing. The take-home point to the audience here is that if you are able to make a diagnosis of positional sleep apnea, you will be able to offer something other than the CPAP. And that is what patients always look forward to, something which is less intrusive than the CPAP. Thank you. Back to PAP therapy itself and back to Dr. Jaykumar. This again is a very important practical question. So when we prescribe a CPAP, it's very important that we advise the right interface to be used. So how do you choose the interface, and What are the practical points that you need to keep in your mind when you prescribe a particular interface for a patient?
So this is a very important consideration when we are choosing PAP therapy, because if the interface, once we have chosen the correct mode, but if we have not choose correct interface, then there will be an ineffective PAP therapy which will lead to leak as well as non-abolishment of the AHI. So hence the ground rule is that the smaller the interface, the bigger the compliance, but at the same time there can be higher the leak. So it's a trade between the compliance and the leakage or the efficacy. And hence, it's not possible for a layman to select all this. So what we do, a practical approach, when the patient comes to us and once we decide that we need this type of PAP, this is the mode which we have selected, and then it comes to the device. So we show them different masks on the Google images that this is an orificial mask. Usually orificial masks are bigger ones. People feel more claustrophobia, and it is having less compliance when it comes to the long term. So, particularly as Sir also told that the facial hairs, if you are having a bigger mass and there is a significant leak and patient is feeling bit of claustrophobic, then it's not going to be that effective. In that case, a smaller nasal CPAP mask or wisp mask or nasal pillow mask will make a more important consideration and improve the compliance. However, we need to be very thorough in examination of the nose and the presence of nasal polyps and nasal obstruction, so that we deliver a good interface. Second is sometimes we give it on the trial basis. So most important thing is when we have a good interface and selected correct mode, the first and foremost the snoring will get abolished. If the patient is still snoring on the interface which we have used, it means it's not effective interface. So this is one practical point which I ask usually when we have given CPAP on a trial based, that if the snoring is there or not. And it also shows that the air is getting leaked through the oral cavity or from the mouth when they are applying the nasal passage. So in nutshell, it has to be decided again on the case to case basis. The ground rule is that the smaller the mask, the greater the compliance, but it has to be balanced with the leakage and the efficacy. So this is what my take on this matter, sir.
Thank you, Dr. Jaykumar. It's very, very important that you choose the right interface, particularly in our country, because we know that an interface itself will cost around 8,000 rupees. And we can't just tell the patient to keep on changing the interface. And if we make a mistake in choosing the right interface, it will also actually end up in poor compliance with the device as well. At this point in time, I'd like to inform everyone that right now we have more than 1,200 logins watching this webinar. It's all credit to the brilliance of our panels and the right choice of the topic by the CCI webinar committee. Congratulations to all of you. We now go to Tarang. Tarang, this question is to you again. You have heard in Dr. Atri's talk about the advanced modes of ventilation, like the AVAPs and the adaptive servo ventilation. So how do these modes affect outcomes in patients with sleep apnea?
So this is something that is a topic of interest right now, even amongst our critical care colleagues, especially when they're shifting someone out from the ICU and they want to, because these are modes that they have been using with invasive mechanical ventilation as well. So first, when you take you to AVAPS mode, is the volume assured pressure support. And this is primarily recommended, or this primarily used in patients who have an overlap of OSA with a bit of obesity hyperventilation syndrome. Primarily used in patients who cannot tolerate in CPAP or BiPAP. These are patients who generally are on BiPAP ventilation, who are obese, but still there is not a good correction of PCO2, or there is not a really good correction of their AHIs. So initially, the studies which were published, it showed that AVAPs improved nocturnal ventilation, but we are getting more and more studies now, the evidence is not very strong there. So a good in-hospital titration study would work as good as what AVAPs would do in these patients with OSA and OHS. But definitely, I think this is a very interesting space to look out for. We will have more data in this regard. Coming to adaptive servo ventilation, so it is basically varying amount of inspiratory pressure on a low level of CPAP. generally recommended in patients who have a concomitant OSA and a central sleep apnea. Generally for central sleep apnea, but care must be taken in patients with heart failure. So there was a SERP HF trial which talked about increased mortality in patients who have a low EF when they were given ASV. Lot more trials which have come in. There are a few conflicting results, but this is primarily reserved for patients who have a combination of OSA and CSS. These must be complex sleep apneas, or even in patients who have treatment emergent apneas. So definitely a space worth looking out for.
Thank you, Tarang. You have summarized both this, the uses of both these modes of ventilation very clearly. And AVAP's average volume assured pressure support is basically to improve the alveolar ventilation in your conditions like obesity hyperventilation syndrome. And adaptive servo ventilation is basically, it came up in a big way about 2 decades back as an alternative even to heart transplantation in patients who had severe heart failure. And as the results of the SERV HF trial have shown us, when you have a patient with central sleep apnea, Cheyne-Stokes respiration, before you start treatment, the first thing that you have to look is at the ejection fraction. If the EF is less than 45%, these patients will benefit only from a BiPAP ST mode. And if you put the patient on ASV, actually, you'll be increasing the mortality in this group of patients. ASV can be used if the ejection fraction is more than 45%. But in the context of our country, we know that adaptive servo ventilation is an extremely expensive device. It comes to 1 lakh for the device itself, whereas you get the same benefit if you use a BiPAP ST mode machine. So that is the status of these conditions. Now, the next question is to Dr. Atri. When you start a patient on CPAP, you have made a diagnosis and you start the patient on CPAP, or you start the patient on any treatment for that matter. How often would you monitor the patient, and is follow-up and monitoring important in a condition like sleep apnea?
The most important question my patients or their family members ask me is, when will this machine go away? Or can we taper it to, let's say, 5 days a week or 6 days a week? So, what I tell them, or what the guidelines tell us, is if there are any correctable factors like obesity and BMI, sinusitis, treat them concomitantly. Means you can clear the sinuses in 1 or 2 days, but to decrease the BMI can require months. So you start the PAP therapy, encourage them to lose weight, improve their sleep hygiene. If the patient is comfortable, then after 3 months, between 3 months to 6 months, you can definitely review the patient. If the patient agrees, you can do another sleep study without the machine to see how the parameters are. But the most important thing is, if the patient does not benefit with PAP therapy, because this is where the trouble starts. So if the patient does not benefit with PAP therapy, try to review them inside 2 weeks, because if you are not giving the right PAP to the patient, sometimes theoretically you can compound the problem. For example, there is a terminology known as treatment emergent apneas, or you may convert a obstructive apnea to mixed apnea to a complex apnea. So if the patient is better, 3 to 6 months. If the patient does not improve, 2 to 3 weeks.
Thank you, Atri. It's very important to follow up any patient who started on CPAP, because we need to know what is happening. We need to review the CPAP data. So in my practice, what I do is, once I start the patient in CPAP, the first review will be after 1 month inevitably, and every 3 to 6 months, depending on how confident you are that the patient will be adherent to the treatment. So you download the data, the patient brings the data, so you can know what the AHI is, how many hours the patient is using, whether the patient is CPAP compliant, whether there is any mask leak, all those things you'll be able to know. And actually, you can improve the compliance and adherence to CPAP better if you instruct the patients for a regular follow-up and the patients come for follow-up. The next question, again, Dr. Jaykumar, very, very important question. Even today, this morning, this was a question which was asked me by a patient. How long should I use the machine, and when the machine can be stopped? So how long will you treat the disease, Dr. Jaykumar?
Sir, I think it is a similar question which we get in day-to-day practice in allergy and asthma, that I have to take inhaler for lifelong. So it's best not to comment. That's what my personal strategy is. I tell that it's not lifelong, but it's also not for short term. As Dr. Atri sir told, that it's mainly for the long time. So what happens, sir? Here, if you will tell and guide patient that it's for the short time or 10 days, 15 days, then what they'll do, they'll not buy it, they'll get it on the rent. and then they'll ask you that how long we have to keep it, and if they're paying 3 months of rent, I think they are almost have purchased half a price or paid half a price of the new machine. So in that case, we have to be very clear with our message that mostly in obstructive sleep apnea, as Dr. Atri sir told, it is related to the obesity. I always tell them that weight loss can be a long-term goal, but correction of hypoxia is very important from the night, from tonight only, and hence it has to be taken. Once we have at least a 10% weight loss, then we can think of, as sir told, restudy, and then we can reevaluate. But at least it's for long term, not for the lifetime. That is number one. Second most important part is that we always review, as sir you told, every 3 months to 6 months we have the data, and gradually, if the pressure requirement is coming down, it means that the patient is benefiting, and the suppose if we have started and titrated the pressure of around 14 centimeters of water, and then slowly patient comes to around 7 and 6, it means that now the patient is improved significantly, and then he might not be needing the PAP therapy. But that happens in very few patients. And I think with a pinch of salt, I like to say that, but that does happen. And hence, we have to tell that, yes, it's not for the lifelong, it's not permanent, but at least it's for the long term. And there are so many benefits. Sir, with this, I want to highlight one another thing, another important aspect which none other treatment modalities offer. That is robust monitoring and data what the PAP therapy gives over the non-PAP therapy and the surgical, like oral appliances, as well as surgical options will not give us that data, that whether the patient has improved a bit or not. They can give us symptomatic data, but not a real-time data which we are using in the PAP therapy. And hence, it makes PAP therapy very much evidence-based, that we can show them on the paper that, look, you have improved this much. And I like to have a small consensus opinion also here, as Atri sir told. How many of us have stopped PAP therapy because of success, or a success of PAP therapy, that the patient is completely asymptomatic? I think, I don't think so.
No, absolutely no.
I had one patient, rare patient, RTA vertebral injury. And I don't know how that vertebral injury caused that apnea, but that was only one person where I could stop the PAP therapy maybe after 12 months. But for OSA or mixed apnea, no.
No.
Yeah, that's the most important thing that we always need to keep in mind. We have to, practically we all know that this is going to be a lifelong affair, but if we tell it upfront to the patient, they may not adhere to the treatment. So at least to ensure that the patient is compliant, we'll have to tell them that let's see as it goes and how we are going to respond. The most important thing is that once the patient is on CPAP, the quality of life will improve. The neurocognitive impairment goes off. They'll be more alert, more fresh, and probably you can prevent many of the comorbid conditions like heart failure or arrhythmias in future. So those are all the important things that should make you insist that the patient use the CPAP regularly. Now to you.
Sorry, may I just jump in just to add?
Yeah, of course.
Just to let you know, in terms of resource, countries with the resources for PAP therapy are a lot less because it's driven by insurance and other reasons, and the government is funding it, like the UK and US. They generally prescribe mandibular advancement devices for all their patients who are mild OSAs, and then they do follow-up studies to see whether they're improving or whether they're worsening. That's first cohort. The second cohort is the patients who have failed CPAP therapy after 3 months or 6 months and who refuse to use it anymore. They're put on to mandibular advancement devices. Yes, if they're moderate to severe category, the caveat is always mentioned that your cardiovascular, you may improve symptomatically if you use the mandibular advancement device every night. Otherwise, your risk for cardiovascular events and CNS events remains the same as the general population or as an OSA population. So those are the caveats that you need to keep in mind. So maybe, in patients who are not affordable, but with mild OSA, you could consider using the mandibular advancement devices. Thank you.
Thank you, Karl. Exactly, I was coming to that. That was the next question which I wanted to ask you.
Mm-hmm.
About this mandibular advancement devices. A lot of patients who inquire where you should go to get a person who can prescribe you these devices in our country. So what is the status in India as of now, and how do you go about it?
I unfortunately, in terms of finding the status in India, I wasn't able to find any concrete data. I put up the question hoping to find it. No concrete data is available, but I do know that there are specialized dentists who have trained in the US and UK, who can be found mainly in the metros. But they're very few and far between. There are a handful in each metro. They're the ones who are trained in molding these bespoke mandibular advancement devices. Unfortunately, cost is an issue, but it's still a lot cheaper than buying a PAP machine, which is probably 40 to 50,000. Within half the cost of that, you can get a bespoke mandibular advancement device tailored to your teeth exactly. So the benefits of that is that it improves comfort, it improves compliance, and as a result, it keeps your airway open at night, reduces airway resistance, and therefore you don't really require PAP device to help reduce the frequency of apneas, the severity of apneas, and you can prevent oxygen desaturation at night. And basically, once you have a patient on an MAD, you need to follow them up again, stick to the schedule, see them after 1 month after they've worn it for 1 month at night, then 3 months and 6 months thereafter because the point of keeping a tight timeline in the first 6 months is you're giving the patient and the families reassurance that they're on the right track. So when you repeat the sleep study after 6 months, you can show that if it's mild and your symptoms are improving based on the lower ESS score, you can say that, see, your work, it's improving and you're doing a better job with it. So, you can do that as well. So that's something that needs to be just kept in mind.
Sir, I would like to have some insights in this. So I had a bit difference of opinion in this. I had a bit consensus and asked our dentists who are practicing in Ahmedabad about how they are doing, and many of them are practicing mandibular advancement devices. They told us the protocol. First, they get the lateral cephalogram, and they also get OPG, and then they'll mold, and then they'll just tell 1 mm and then 2 mm, and that's how they'll do. So the rough cost, what I got is around 75 to 80K, which is equivalent to an PAP therapy device, which we are having in India. So that is one thing, that it is almost similar in the cost. Second, as we talk about OSA, it is multi-level obstruction. Well, it is word classification, velum, oropharynx, tongue, and epiglottis. With the mandibular advancement device, although we are treating mild to moderate, mild OSA, but only one aspect of that 4 components. And hence, it's then anteroposterior anteroposterior dimension only which we are treating. Third and very important thing is there is no real-time monitoring what the PAP therapy gives. So although patients usually ask us, they are sometimes non-compliant or they seek options, particularly in moderate to severe OSA, we always tell the PAP therapy is the best thing, evidence-based treatment with a real-time monitoring and a multi-level, it corrects the multi-level obstruction. These are certain points which puts PAP therapy, and if we come to the cost aspect, they are almost equal when it comes, at least in Ahmedabad. So I think it makes PAP therapy more favorable over oral appliances, but still there are subset of patients where it is practiced, particularly those who are not tolerating CPAP, where we are failing with trying many interfaces or the modes as described. There are certain modes like a ramp, and that is I found it very particularly appealing, because a ramp is one thing which when set for 15-20 minutes, it very soothes the experience of the PAP therapy. So I think something we can do to increase the compliance to PAP therapy, and that should be the answer to our patients. That's what I think, sir.
I think what I just summarize is that it's high time that we should have a multidisciplinary discussion between the pulmonologist who practices sleep medicine, the sleep dental doctor, and the ENT surgeon, so that we will be able to offer the best possible treatment for a particular given patient. Having said that, I do agree with you that data is highly loaded in favor of CPAP because of the evidence that we have. But from the patient's perspective, I think they always prefer something which is less intrusive than the CPAP. And for them, always these devices are more appealing. and they may use it for a longer period of time, and their compliance and adherence to be will also be good. And of course, you need to do repeat sleep studies to see whether they have improved with treatment or not. Having said that, let us now move to Atri. Again, another important question. We have heard in Dr. Karl's talk the role of surgery in the management of sleep disordered breathing. So, which patient would you probably refer to an ENT surgeon or a maxillofacial surgeon upfront when you have made a diagnosis of sleep disordered breathing? Atri.
Okay. If clinically I am suspecting this person has significant adenotonsillar hypertrophy, because that is something surgically wonderfully correctable, a strong family history of asthma with symptoms of nasal allergy, that would be strongly correctable. Third, this is rare. Someone who is failing PAP therapy, and I am unable to find what is wrong with respect to interface or device selection. But upfront would be obvious signs of sinonasal allergy. Maybe someone with a facial accident, facial injury in an accident, may require a ENT or a maxillofacial surgeon for corrections. Others can also add to this based upon your experience.
Okay, Atri. Basically, what we do is that if we have a patient with a low BMI, mild OSA, we always have an ENT assessment done. Basically, that also includes a DISE, a drug-induced sleep endoscopy, to know how many points of obstruction there are in the upper airway and whether they will benefit from anything other than the CPAP. So, for that, at least for that particular group of patients, or patients who have moderate to severe sleep apnea, but they cannot tolerate CPAP for some reason or the other, we will have to look for alternate options. So, that will be the practical thing. Now to you, Karl. I'll ask you a question that has been making headlines last week all over. Most of the newspapers also had that as a drug has been approved by the FDA to treat sleep disordered breathing. So what is that drug? How does it act? And what is the evidence behind that? Karl.
The marketing is that it helps in OSA, but it's actually just a GLP-1 inhibitor, which is used to reduce its so I was talking about tirzepatide, which is one of the new GLP-1 inhibitors that have been launched by Eli Lilly. Lots of marketing behind it as a wonder drug, but so there are some benefits, but the main benefit will be in obesity. So reducing obesity, helping reduce BMI. The good news about this study it was ran over 176 months, so that's a good significant amount of data. The endpoints, the primary endpoint was a reduction in AHI, which was seen, but again they depend on patient. But overall, there was a reduction in AHI compared to the placebo arm. In terms of secondary outcomes, they did find that the ESS scores in these patients, as the AHI improve as the weight reduced and the AHI reduced and improved, their airport sleepiness score was starting to trend towards the normal. So their symptoms were they were no longer feeling as sleepy or as tired. They were more awake, alert. They were feeling more energetic. So these are all positive responses. In terms of the negatives from the study, they found that while there is reduced weight and reduced AHI, what is the effect on PAP therapy? Because PAP therapy was still continued in these patients who were diagnosed with OSA, who were put on tirzepatide. So what is that effect that was not taken into account as yet? And what is the PAP compliance in those patients that was not taken into account as well? So I know 52-week outcomes have come out of this as yet for patients who have been on the tirzepatide long term. So good study, good paper, but the whole point of tirzepatide is you have to do proper patient selection. And is tirzepatide better than bariatric surgery? The answer is still no. But tirzepatide is a very good option for patients who are not fit for bariatric surgery. The other positive thing is, as you know, as the weight reduces, the blood pressure, or the 24-hour blood pressure levels were reduced as well in the patients. And those who are pre-diabetic or early or low diabetic, while they were on tirzepatide, their diabetes did not worsen. Only in 2% of the patients did the diabetes not improve or worsen, but the rest, there was an improvement. So there are some metabolic benefits to it, but it's not a direct wonder drug for OSA. We still need to evaluate. We still need to treat as per the guidelines and per patient symptoms. This can only be used as an adjunct and hopefully help them reduce weight. before you reassess what you want to do on a treatment basis.
Thank you. Thank you, Karl. I'll just come to you for one more question. Again, a very important new treatment modality that has been approved in the West, not yet available in our country, that is hypoglossal nerve stimulation. So can you highlight hypoglossal nerve stimulation, how effective it is, and where is the role?
Yeah. So again, hypoglossal nerve stimulation is an option given to a certain subset of patients who do not tolerate CPAP or refuse to take CPAP any longer. There are some strict inclusion guidelines. It is based on an MDT, based on pulmonology, dental, ENT, and if required, psychiatry. So we have these patients, the MDT that requires. So the inclusion criteria include, like I said in my presentation, they have to have moderate to severe sleep apnea. So it's between 20 AHI to 60. Previously, it was only offered to the severe group, but it was reduced in the last, at the early of this year, it was approved from 20 AHI up to 50 or 60. The other important thing is that you have to have proper dental and ENT evaluation. When you do the DICE, there should be no concentric. It should only be an anterior posterior collapse with no concentric narrowing, because if there is concentric narrowing, you're eliminated. It won't succeed. The other thing is the negative is it's an invasive procedure. It's a device that is similar to a pacemaker, a little smaller, battery operated. It sits in the right above in the intercostal space, right on the right side of the chest. So you need a surgery for it. One lead is in the intercostal muscles, and the other lead goes into the to stimulate the hypoglossal muscles on both the right and the left. So it's a major surgery requiring GA, and so it's basically what happens is once the device is implanted, you have a remote. Each patient is given a remote, and you switch it on before you go to as you go to sleep or before going to sleep, and then when you get up in the morning, you switch it off. You just have to tap it on there, and it provides impulses. So that has to be titrated. Once you have the surgery, you're then as an inpatient, you titrate up to about from 4 hertz all the way up to what is comfortable. So there should be just enough sting, but not pain, and enough, and then there's a reduction in AHI. So we compare the results from pre-treatment at a 2-month interval post-surgery and 6 months interval post-surgery. So the whole point is this device stimulates the muscles to keep it taut, prevent anteroposterior narrowing or collapse, and then thus improving ventilation and then reducing the apneic events at night and leading to really good outcomes. But the point is it's a very, very narrow, small group or subset of patients who actually meet the criteria, meet the MBT approval, who actually get operated. As of now, the guys in St. Thomas's has only operated 8 or 9 patients successfully, but the outcomes have been quite good. So the importance in this matter is patient selection is paramount because it's a major surgery, and if it fails, then lawsuits can be a big. So you have to understand that this is not. I don't think it's going to come to India anytime soon, but it's just something to keep in mind, and it's something we hope to offer patients maybe in the next couple of years based on the results in the UK. But it is being used in the US to great success. I think they have reached 500 plus patients where it's been quite successful.
Thank you, Karl. One last question to Dr. Atri. How long do you give a trial of PAP therapy before reconsidering a diagnosis of sleep disordered breathing, and further the patient needs further evaluation or reassessment?
Generally, people who improve say the same by 3 to 7 days. So if in 7 to 10 days there is no improvement and person actually feels more discomfort after the machine, unable to complete it through night, then we must think of reconsidering. Again, interface first, check for leak, check for compliance. If not, then we need to think about other things for sleep disorder breathing. So 3 to 7 days patient feels better. If not, you again work on the patient.
Okay, thank you. We have some questions from the audience as well. There is a question from Dr. Saita Baumik from Tripura, Agartala. what are the options available on sleep medicine fellowship in India? Karl, would you like to take it? And I'll add once you give your opinion.
I can't tell you I don't know I can't give you the list of the centers, but one of the centers that I can highly recommend is the team at St. John's in Bangalore, St. John's Hospital. They run a fellowship which is supported by the World Sleep Society, is what I did. So there, it's quite an integrated and comprehensive sleep fellowship where you'll understand both sleep apnea, but also the other spectrums like insomnia, restless leg, periodic limb movement disorders, and other disorders. So I think considering something like that will be really good. You can get their information. Yeah.
And also, I'd like to add that National Board is going to start a course fellowship on sleep medicine, because I'm also involved in that drafting the syllabus and getting the course running. Probably in next year also, we'll have an FNB in sleep medicine approved by the National Board. So that will be an approved course which is coming up in the country. So there is a question from Dr. Jayaraman from Chennai. Like tumor board, is there any name like the sleep board? So for the multidisciplinary discussion, of course, you can call it whatever name you like, Dr. Jairam, but it's very important to keep in mind that a multidisciplinary discussion is always beneficial to the patient, especially when some mild to moderate case of sleep disorder breathing. Again, a question from Dr. Saikat Baumi from Tripura. How common is mild to moderate AHI getting diagnosed, and when should we suspect mild AHI apart from sleepiness? Jaykumar, can you take this?
So this is one of the first question when I entered into CMC fellow. One of my professor, Dr. Ranjit Singh, he asked me one question that what is the most common disease in the respiratory medicine? I told tuberculosis. He told no. I'm talking about back then 10, 12 years. And then he told OSA. And to me, it was a type where I could see OSA almost all the that everybody. I started looking at the OSA part, and this was one thing which triggered that mild OSA is very common, but they are asymptomatic, particularly when it comes to the female patients, where they don't have excessive daytime sleepiness, but insomnia or sleep-related other disturbances more than the sleepiness. So I think it's very difficult to estimate. I don't have the exact percentage of prevalence. Well, we have a percentage around which estimates from 17% to 28% of population of OSA. But from them, I think many of the patients will be having asymptomatic OSAs, and which may contribute to the comorbidities also. Many of them are missed. Like we have a list of comorbidities like resistant hypertension, pulmonary hypertension, heart failure, arrhythmias, uncontrolled diabetics. They may have many hidden or occult obstructive sleep apnea, still not having the sleepiness part. So I think this is one thing when you're having the comorbidities or uncontrolled comorbidities, you have to look into that.
I want to add a new dimension to this. In my clinic waiting area, I have put a stop bank questionnaire on a board in vernacular language. So lots of the patient attendant while waiting there, when they read that chart, they realize that they may be having those symptoms. They volunteer to get themselves tested, and that is how I am picking up mild to moderate AHIs. So this can be done by people.
So the feeling is mutual. I also share that experience. I also put that in vernacular language, and then once they are waiting in the OPD area, they come that I also have this. They come for another thing, and then they get the sleep study done, and then we pick up that the person is having OSA.
Thank you. There is a question from Shivani. What is the role of DICE and dynamic MRI? Again, I think Karl, can you take that question? Role of DICE and dynamic MRI.
So dynamic MRI, I'm not very familiar with at all. I have no experience with dynamic MRIs, but I think it will play a role. It's just that you need a very good radiologist to work with you in terms of gaining the right measurements, looking at the right area from the velopharynx all the way down to the hypopharynx. So you need to have those measurements. Look at the baseline. Look at the look at the change in dimensions. But in terms of DICE, the main role of DICE is to look at whether there's an anterior-posterior collapse and then you can use other interventions, like for example using a MAD, or if you need to later on hypoglossal nerve stimulation. Whereas if you have to have concentric collapse and you have multiple levels, then you can consult with and they failed PAP therapy, then you can consult with your ENT, and then palliative pharyngoplasty will be useful in those patients. So that's something that our team, the team at Guy's does quite often, especially those who failed HSN, for those who are candidates for hypoglossal nerve stimulation. But when we do the DICE and we find that they have multi-level concentric collapse and they're refusing CPAP because they've already had a trial of CPAP or BiPAP for a while and have failed that, then we offer the surgery for them. So that's the only real indication at the moment for DICE. But I think if you're really interested in sleep and sleep disorders and have a practice, it's something that you can, since you have the skills in bronchoscopy, as you do more and more yourself and attend more and more conferences in the US and UK, you can get more insights, and then you can start tailoring those protocols to the Indian setting, which is very, very important for all of us to do. We get guidance from the West, but we need to tailor things like stop bang and everything to our Indian setting so we get better results.
So I'll just like to add in a minute only, sir. I'll just like to add because I have done it. Sir, the main problem with the DICE, where we are using it, particularly in the lean OSA, and second, where these are CPAP resistant, where we are particularly want to know about the epiglottis level. Now, the problem is that we need to induce the slip. And for that, we need to have the actual bispectral index. And the problem is that we don't have. Now, many of our ENT colleagues, they use snoring as a surrogate marker of sleep, which is a very rough indicator. And then we have to use TDI, that is target dose infusion of propofol, to just go into that part of the bispectral index. So what we had in our setup was GE entropy. And what we got with our anesthetist team on board is B's equivalence of the entropy. And then we reached to the target dose infusion. And then we saw and classified according to the vote, and the patient was having concentric collapse and was not actually the candidate. So this is how we did. What we are using DICE in our setting is basically, as Atri sir told, those who are not improving with the CPAP after 7 days or 10 days, and those who are having lean OSA, where there can be surgical correction to what level, and we always have our ENT backup with us so that we can have that, and the anesthetist backup. So this is in a nutshell how we do the DICE and our setup, sir.
Thank you. The last question, again from Dr. Shivani Swami of Jaipur. Karl, please take this question. Is Tirsapride useful in non-obese OSA patients?
I don't have the answer for the non-obese patients. I'm sorry. This was specifically targeted at patients. The inclusion criteria for Tirsapride was BMI of more than 32. So I don't think there was a trial, and I am not aware of it being used in non-obese patients.
Again, I also feel the same, because it's basically by reducing obesity.
Even in the prescribing information, it is not mentioned that any off-label use in non-obese, it is not mentioned in the prescribing information.
Okay.
So until robust evidence, I would want to avoid.
Yeah. We are coming to the end of this brilliant panel discussion. Just one last take-home message from each of the panelists before we wind up. We'll start with Dr. Jaykumar Mehta.
Thank you, CCI, for having this wonderful discussion and very thorough and elaborate discussions on PAP as well as non-PAP therapies for sleep apnea. And thank you for having me on board. Thank you so much.
Thank you. Dr. Tarang.
Yeah, thank you so much for the opportunity to learn from the best. I think one of the take-home messages that I have today is that the job of a sleep physician actually begins when you give your patient a PAP therapy. As contrary to prescribing a sleep study is the more easier bit. So just PAP is not the end of all treatments. There are so many new treatments, and there are so many emerging treatments that Dr. Karl spoke about. So I feel my take-home message is your job begins when you have given your patient the PAP.
Thank you. Dr. Karl?
First, I'd like to thank you, Dr. Arjun, for being a fantastic moderator. Thank you so much for coordinating all of us. Thank you, CCI, for giving me the opportunity, and thank you, the audience, for listening. And I hope you found this beneficial. My take-home message is that from 2025, in many modes of medicine, including our specialty, whether it's sleep or respiratory diseases, is tailoring treatment to the patient individually. The importance, as you know, since 22, phenotyping in asthma, COPD has been very important, and that's now going into each and every field and subspecialty. So phenotyping and then genotyping when available, that will be important. So tailoring your treatment, because we are all unique signatures, and I wish all of you the very best. Thank you so much. Have a good evening.
Thank you. Atri, the last word is yours.
Yeah, very encouraged to see 1200 plus logins on perhaps last CCI webinar for this year. Please talk about sleep medicine to your non-pulmo medical colleagues, because we are on the tip of an iceberg, and these people will give us more sleep patients than who will directly come to a pulmonologist.
Thank you, Atri. I would like to end by echoing what Karl has said. We are in the era of phenotyping and in the era of precision medicine where we talk about treatable traits. So in future, we will be actually approaching sleep disordered breathing also in the same way. When we have a patient with sleep apnea, we'll have to identify the treatable trait and give the patient the best possible treatment. It could be CPAP for one, it could be a drug for the other, it could be a mandibular device for the third patient, or a surgery for the fourth one. So that's the way forward. And I think this webinar has really set the tone for all the possible treatment options that we have to offer to our patients with sleep apnea. I'd once again like to thank all the panelists. You have done a brilliant job. They have covered all the areas that we needed to discuss today. Dr. Jaykumar, thank you so much. Tarang, thank you so much. Karl, thanks a lot. And of course, my good friend Atri, you're absolutely a change of roles this time. You usually would be the moderator and I would be the panelist. So we have changed the roles this time. Thank you so much. And thanks CCI for having this webinar and having all of us here today. Thank you very much. Good night.
Thank you, sir. Good night. Good. Thank you, everyone.